done. So good morning, everybody. I know people are still coming in, so we're going to give everybody at least another minute before we get started. On this cloudy, but nonetheless still humid day in Baltimore. Okay, it looks like things have slowed down. Just see if there's any more upticks. Okay, very good. So, good morning, everyone, and thank you for joining us for the Maryland Insurance Administration's annual Life and Health Industry Meeting. I'm Kathleen Borain, and I serve as the Maryland Insurance Commissioner. The purpose of today's meeting is to discuss 2023 legislation, regulations, operational issues, and any other matters of concern to the industry or stakeholders. We thank everyone who reached out in advance with questions or agenda recommendations. Joining us today are folks that you all know quite well. David Cooney, who is the Associate Commissioner of Life and Health. Mary Quay, the Associate Commissioner of Market Regulation and Professional Licensing. Joy Hatchett, the Associate Commissioner of Consumer Education and Advocacy. Brad Boban, our Chief Actuary. Patty Dorn, our Health Insurance Administrator. More information on that to come. Joe Sviatko, our Communications Director, and Jamie Sexton, who is the Director of Health Insurance and Regulatory Affairs. So this public industry meeting is being recorded and will be posted on the MIA's website. We have a robust agenda, but as time and technology allow, we do want to hear from you. We will take your questions. You can post them in the chat if you like, or if you want to speak during the industry comment portion of the agenda or stakeholder portion. Please let us know using the chat feature, and we'll move you over in order to make your comments verbally or ask your questions, in person, so to speak. And again, I always remind people to please, during the course of the meeting, stay on mute with your video off. If you are, once you are brought over, just to assure that the sound quality and the video quality are good throughout the meeting. Before we start today's formal agenda, there were two items that I did want to address. The first is the MOVEit data breach that has impacted many industries globally, as well as several federal agencies and state agencies in some states. So the first thing that I want to assure you that the MIA's CIO and CISO have confirmed that MIA systems have not been impacted. We are continuing to monitor them, and we have proactively implemented the recommended mitigation steps. But I wanted to assure you that there is no indication that any information that is or data that is held by the MIA has been compromised in any way. For those of you that haven't followed it, what this is about are criminals that have exploited a vulnerability in Progress Software's MOVEit file transportation application, which is used by thousands of organizations around the world. A number of organizations whose supply chains use the MOVEit app have suffered a data breach as a result, with customer data being stolen or held for ransom. It's hit a broad range of industries around the globe. That includes financial services industries, and it includes the insurance industry. The MIA has received breach notices to date from several carriers and third-party administrators and vendors. That seems to be, at least what we've seen so far, is that the breaches are at the vendor level. One of the areas, for example, of particular vulnerability have to do with master death file data vendors. So our expectation and our ask is that there be an immediate and complete assessment of the risk that your information or data may be compromised, or your data in the hands of vendors may be compromised. And then if you discover that that has occurred, please obviously let us know as quickly as possible pursuant to the notice rules for a information security breach. And Mary will talk more broadly about the legislation that was passed last year and which will go fully into effect this October for most insurance carriers. The second issue that I'll touch on just very briefly, and this is going to be primarily of note for long-term care companies, and that is that the Supreme Court of Pennsylvania issued its opinion yesterday, upholding the rather unique rehabilitation plan that was entered into by the trial court at the behest of the Pennsylvania commissioner and the receiver. The short version of the issue that was before the court was whether, in the context of a rehabilitation, a liquidation, but a rehabilitation, a receiver can unilaterally change policy, contract terms, and rating terms without the approval of the state of issue. So essentially, in that case, what the receiver did was they said, we're going to go in and we're going to re-rate everyone as if, looking at factors that we didn't even consider back, 20, 25 years ago or more when these policies were issued. Some of these are very, very long, old books of business going back to the 1990s. And the impact on, the most senior of citizens has been devastating. And in Maryland, 96% of the impact would have of rate changes, sometimes as much as 1,200% rate increases would have been borne by women over the age of 80. So when we were asked to approve those for a variety of reasons, we said, absolutely not. It's completely inconsistent with Maryland law. You are not allowed to go back and re-rate based on factors you didn't even consider, et cetera. But nonetheless, the Pennsylvania commissioner, through the receiver, took the position that they can do that because the company is in rehabilitation. The laws of no other state matter. So over 35 states objected to the approach taken by Pennsylvania. There are lawsuits that have been filed in our state all over the country. We have not completed our review of the opinion, but it is our sense early on that Pennsylvania has just failed to give full faith and credit to the laws of other states as they relate to the conditions for doing business in our state, which includes filing your forms and rates where the statutory law requires it. It's our expectation that if SHIP and the receiver persist, we will continue to disallow SHIP's rate changes. And if they try to move forward with them, we're very likely to file a cease and desist order and seek a TRO. So for those that follow or are part of the long-term care industry, that's just a very, very quick update, and there will be more to come, no doubt, as we move forward. So with that, let me now ask David Cooney to get us started on our formal agenda, which begins with the discussion of 2023 legislation impacting the life and health industry and other updates from his division. So David, let me throw it to you.
All right, thank you, Commissioner, and good morning, everyone. So as with most years, there were many life and health bills impacting the industry that passed this year. However, there are a few in particular we wanted to highlight because they will either require carriers to submit form filings or they impact filings that are already under review by the Life and Health Unit. The first bill I want to mention is House Bill 376/Senate Bill 184, which adds a new section 15-814.1 to the insurance article, prohibiting carriers that provide coverage for a diagnostic breast examination or a supplemental breast examination from applying cost sharing to these examinations. Note that this bill does not create a new mandate, but it places a cost sharing prohibition if these services are already covered under a contract. Also note that these are services that are not included under the standard ACA preventive care benefits. And because these diagnostic tests would not qualify for the preventative care safe harbor under IRS guidelines for HSAs, the bill does include a provision allowing carriers to apply the deductible to these exams for any enrollees covered under HSA-compatible high-deductible health plans. The requirements go into effect on January 1st, 2024, so carriers need to ensure they file necessary revisions to forms prior to that date. Also note that these cost-sharing prohibitions will apply to the 2024 non-grandfathered individual and small group plans that are currently under review by the MIA. And MIA staff will be ensuring that the forms are amended to comply with this law. Moving on to House Bill 785, Senate Bill 515. This law also goes into effect on January 1st, 2024, and it requires carriers to establish a process for requesting an exception to a step therapy or fail first protocol. The law requires the request to be granted under specified circumstances, including when the prescriber of the medication determines a step therapy drug is contraindicated or is expected to be ineffective based on known clinical characteristics of the insured, when the insured is stable on a prescription drug that has already been prescribed, or the insured has previously tried a drug similar to the step therapy drug, and the prescriber discontinued use of that alternative drug due to ineffectiveness or adverse reactions. The bill also requires that electronically submitted step therapy requests must be granted in real time if no additional information is needed by the company to process the request, and requires all other requests to be granted within 1 business day after all necessary information has been received. The law applies to any contract that covers prescription drugs and includes step therapy or fail first protocols, and we will be requiring the new exception process to be described in the contract. Private review applications that include policies and procedures related to step therapy should also be amended to comply with these new requirements. Next up is House Bill 815/Senate Bill 965, which establishes a new mandated benefit for certain contracts to cover recommended follow-up diagnostic imaging to assist in the diagnosis of lung cancer for individuals for whom lung cancer screening is recommended by the U.S. Preventive Services Task Force. The new mandated benefit will generally apply to all individual and group HMO contracts and all individual and group contracts offered by insurers and nonprofit health service plans that provide hospital, medical, or surgical benefits on an expense incurred basis. The mandated benefit will not apply, however, to non-grandfathered individual and small group health benefit plans that are subject to the essential health benefit requirements of the ACA. And now I'd like to take a moment to just remind carriers that for any new mandated benefit, the mandate will generally not apply to non-grandfathered individual and small group health benefit plans, which I'll refer to ACA plans going forward, even if the scope of the new law appears broad enough to encompass these types of plans. And this is because of the benchmark plan requirements established under Section 31-116 of the insurance article, which expressly states that the benefits of the state benchmark plan are the benefits required in ACA plans, notwithstanding any other benefits mandated by state law. Therefore, in order for a new mandate to apply to ACA plans, the statutory text for the mandate would generally need to include text explicitly stating that the new mandate applies irrespective of Section 31-116. Now, for this particular bill, it also includes a cost-sharing provision, which does, however, apply to all contracts that cover lung cancer screening and diagnosis, including, as applicable, ACA plans. The cost-sharing provision prohibits carriers from applying cost-sharing to lung cancer screening and diagnosis that is greater than the cost-sharing applied to breast cancer screening and diagnosis. The bill provides that high-deductible health plans are still permitted to apply the deductible to any follow-up diagnostic lung imaging, since these benefits would not qualify for the IRS Preventive Care Safe Harbor. We will be ensuring the contracts comply with all these requirements as part of form review this year. Now, moving on again, the main purpose of House Bill 1148 and Senate Bill 582 was to establish the Commission on Behavioral Health Care Treatment and Access for Maryland, which is extremely important and which will inform the state's comprehensive strategy for addressing behavioral health care needs over the next several years. However, the reason we are highlighting this bill for the life and health industry meeting today is specifically to note one of the secondary provisions of the bill, which is related to telehealth. This bill, as well as a separate bill, Senate Bill 534, the Preserved Telehealth Access Act of 2023, extends certain telehealth coverage requirements for health insurance under Section 15139 of the insurance article that were scheduled to sunset on June 30th, 2023. Specifically, the bills provide that carriers must continue to cover audio-only telehealth, and must continue to reimburse providers for telehealth services on the same basis and at the same rate as if the services were delivered in person. Both of these requirements were extended through June 30th, 2025. House Bill 1217/Senate Bill 805 creates another new mandate that will go into effect on January 1st, 2024. And this bill requires certain contracts to cover biomarker testing for the purpose of diagnosis, treatment, appropriate management, or ongoing monitoring of a disease or condition that is supported by medical and scientific evidence. As with most new mandates, this will generally apply to all individual and group HMO contracts and all individual and group contracts offered by insurers and nonprofit health service plans that provide hospital, medical, or surgical benefits on an expense incurred basis. However, for the reasons described earlier, the mandate will not apply to non-grandfathered individual and small group health benefit plans that are subject to the essential health benefit requirements of the ACA. Form filings should be submitted with the MIA for all contracts that are subject to the law in order to amend the contracts to include coverage for the new mandate. The next bill, Senate Bill 724, is an MIA departmental bill that expands the method by which a carrier must provide the initial notification of an adverse decision to the member, the member's representative, or the healthcare provider acting on behalf of the member. The bill is intended to modernize outdated language in the existing law that required the initial notice of an adverse decision to be communicated orally. The law will now permit the initial notice, with the consent of all parties, to be given by electronic means such as facsimile, email, or an online portal. This will align the statutory requirements for providing initial notices with actual practices and the means by which providers and insurers prefer to communicate. The law goes into effect on October 1st, 2023, and we anticipate receiving filings for private review agent applications, as well as for any insurance contracts that describe the appeals and grievance process in the forms. Last up is Senate Bill 725, and I'll spend a little more time addressing this bill, which was also an MIA departmental bill. The bill was intended to modernize the anti-rebating statutes in the insurance article to allow carriers to provide consumers with no cost or reduced cost value-based services outside of the insurance contract. In recent years, carriers have increasingly sought to offer products and services to consumers that, while not insurance, are related to the insurance product being offered. However, under current law, these products and services can only be lawfully offered if they are specified in the insurance contract. NAIC Model 880, the Unfair Trade Practices Act, was recently revised to allow insurers to make these offers of value-added services outside the insurance contract. While not identical to the NAIC model, Senate Bill 725 aligns with the model by amending sections 27-209 and 27-212 of the insurance article to clarify that the statutory prohibition on rebates and inducements does not apply to the extra contractual offering of certain products and services by an insurer in conjunction with a policy. For life and health insurance, the products or services must be substantially related to the insurance with which they are offered, or they must be intended to enhance the health of the insured. The products or services must be offered to all policyholders that have purchased the insurance policy or annuity contract, and the law prohibits carriers from increasing the premium or denying a claim on the grounds that the policyholder accepted, rejected, used, or failed to use the product or service. Under Senate Bill 725, these services are still permitted to be included in a form of rate filing, but if they are included in the filing, the carrier is generally prohibited from discontinuing the product or service during the term of the contract unless the policyholder consents in writing. The bill authorizes the MIA to adopt regulations to identify the types of products or services that are permitted to be offered, but at this time, we do not have immediate plans to do so. The MIA already has significant experience in reviewing the types of value-added services that are currently being offered in the market, since carriers have been filing these services in the insurance contracts in accordance with existing law. We intend to continue to monitor the offering of these extra contractual benefits by insurance carriers and collect information on the types of services that are being offered in order to determine whether regulations are necessary. So that wraps up the legislative recap. And Now turning to general updates in the Leatherton Health Division, I'd say the area where we have the most updates and changes is network adequacy. So after a sometimes painfully long multi-year effort, the MIA's revised regulations for health benefit plans did go into effect just recently on May 15th, 2023. The final regulations were substantially the same as the regulations proposed on February 12th, 2023, with just a handful of clarifying changes. The new regulations include significantly more data reporting requirements than the prior regulations, including data on out-of-network claims, out-of-network referral requests, complaints related to network adequacy, and telehealth utilization data. While this data will not necessarily inform determinations of compliance with network adequacy standards, it will help provide us with a better picture of network access and gaps across health plans, across provider specialties, and across the various geographic regions of the state. However, as stated in the regulations, these new data reporting requirements only apply to access plans submitted on or after July 1st, 2024. On the other hand, the remaining regulatory changes went into effect immediately. This includes the new specific metrics related to mental health and substance use disorder services for travel distance, essential community providers, and appointment waiting times, as well as the provisions that standardize the format of access plan submission and the required methodologies for measuring compliance with the access standards. Now, typically, the annual access plans for health benefit plans are due on July 1st of each year. However, as explained in MIA Bulletin 23-8, which was issued on May 5th, the MIA is extending the deadline to file the access plans for 2023 until October 1st. The reason for the extension is to provide carriers with additional time to incorporate the new requirements of the revised regulations, since regulations were proposed and finalized later than we anticipated due to publication delays that were outside of our control. We also fully appreciate that it will take time to implement the new methodologies for measuring the standards, and also that the recruitment and credentialing process for new providers can take several months to complete, as permitted under current Maryland law. So we recognize that even with the extended due date, carriers may still not have sufficient time to fully implement the new standard methodologies or completely resolve all network deficiencies that may have been previously unanticipated. So we will take all this into account when reviewing the 2023 access plans, but we expect carriers to undertake all reasonable good faith efforts to comply with the new standards and adopt the new methodologies. The MIA does not intend to take a heavy-handed enforcement approach for 2023 as long as carriers can sufficiently demonstrate their efforts to comply, including by providing documentation of any operational challenges that hindered compliance with the new standards and explaining the steps they are taking to address any new deficiencies and achieve compliance by 2024. Still, we deliberately chose not to just defer the effective date for all these new standards because we determined that it was critically important to collect initial data on carrier performance against the new standards as soon as possible, particularly with respect to the increased granularity for mental health and substance use disorder metrics. Bulletin 23-08 also provides additional guidance on the filing process for 2023 and includes several important reminders that should be reviewed prior to filing. The bulletin explains that the MIA developed new filing templates to standardize the format of submission, but that these templates will remain optional for carriers to use in 2023. We are soliciting comments from carriers on the 2023 templates, and we will incorporate carrier feedback before finalizing templates for 2024, which will be required. And we are also in the process of scheduling virtual carrier workshops to bring carrier subject matter experts who actually work on the filings together with MIA staff to discuss network adequacy issues as a group. These workshops will focus on implementation of the new regulations, including how the MIA interprets various requirements, and will provide an opportunity for the MIA and the carriers to share insights on best practices and identify common filing deficiencies that can be avoided going forward. We are still finalizing dates, but the first session will likely be held in early July. And as requested by various carriers, the first session will include a walkthrough of different scenarios of how the new telehealth credits may work. Lastly, I just want to mention that the reviews of the 2022 access plans are wrapping up, And determination letters and orders should be issued for all plans well before the filing date for the 2023 access plans. And that concludes my updates for this today.
Thanks, David. I appreciate that. And I'm also, I don't say it out loud often enough, most appreciative to your unit, particularly for getting us all caught up on the network adequacy of the plan. So we are at this point in time fully caught up, and everything is sort of ticking along as it should in terms of the timing of those for the reviews following the submission. So I know that was a heavy lift over the last 2 years, and thank you for all of that. Let me just take a second and see if there are any particular questions of David in any of the items that he has discussed before we move on to the next section of the agenda. I know we have a comments from industry section, and we can certainly, and we will certainly do that. And you can save your questions or comments for then if you wish. But while it's fresh in everybody's mind, and we don't have the biggest group in the world here, let me see if anybody has in the chat any questions that they want to ask, or if they want to be brought over to ask a question. I'll just give people about just a few seconds to indicate that they want to jump over now for questions as opposed to waiting till the end. Okay, I don't see anything. So therefore, David, that means you did a phenomenal job of explaining everything because nobody had any questions. Yay. So Mary, now let me turn it over to you to talk about your agenda items.
Okay, thank you, and good morning, everyone. First, I wanted to talk about the Mental Health Parity and Addiction Equity Act, or MAPIA filings that we have been reviewing. These are filed pursuant to Section 15-144 of the insurance article. And we are continuing to review the MAPIA filings that were received in 2022. The reviews so far have been to determine whether the submissions are complete, and most of them have not been, as we have previously said. The process has been that we will send a very detailed letter after the first review, and then we review the second submission and issue an order at that point if we are still seeing substantial non-compliance or substantially incomplete filings. So far, we have issued orders against 2 groups of companies. I know that we have received 1 hearing request. I'm not sure if the second company has requested a hearing yet. Of course, we would like to move on to substantive reviews as to whether companies are complying with the parity standards as soon as possible. We are expanding our resources to complete the reviews by using additional contractors, and we have hired a new full-time employee who will start with a focus on MAPIA filings. We continue to participate in the NAIC's MAPIA working group and tracking what other states with similar filing requirements are doing and sharing information on best practices. So we are trying to be consistent with other states while following the guidance in our statutes. Filings will be required again in 2024, and we are reviewing the instructions for filing. We plan to issue a bulletin soliciting stakeholder comments on the instructions and the filing requirements. Again, we have to follow the statute, but we are doing our best to be consistent with other states and to listen to stakeholders so that we can make this as smooth as possible. And we hope that the next round of filings will be more complete initially. And so we look forward to hearing your concerns and getting your help on those comments. The other topic I am addressing today is cybersecurity, as the commissioner mentioned. Title 33 of the insurance article took effect last year. The requirement to report cybersecurity events that meet certain criteria took effect last October 1st. The MIA issued Bulletin 2213 to explain the requirements and how to report a cybersecurity event. There is a reporting form on our website for any cybersecurity events that must be reported under the law. I want to emphasize that the website form is the way to make a report to the MIA. It was designated in the bulletin as the way to make a report. The report is due no later than 3 business days after the carrier has determined that a cybersecurity event has occurred. We have heard from one carrier that they were hesitant to use the form because they did not think they had enough information yet. And it is important to use the form and make an initial submission within the 3 business days. We need to know about it. We do not anticipate that you will have all of the information at that time, but we need the prompt communication. We have a process to evaluate the reports and determine a schedule for updates. There may be circumstances in which we need a discussion the day of the report to learn more and set an update schedule. And that happened last week as we started to get notices involving the MOVEit vulnerability, and it appeared that the notifications we were getting were mostly for one vendor, and we did have a call with a carrier and that vendor the day we received the reports. It is important for us to be able to act quickly. If it is less urgent and not ongoing and the information is complete initially, we may send written correspondence through email to request additional information. We may send written notice with a schedule for updates. However, carriers do have a continuing obligation to provide updates and supplements to the original information. And this obligation does not depend on requests by the MIA to receive this information. So this year, the next phase of the law takes effect on October 1st. Section 33103 requires a written information security program and lays out all of the requirements for that security program. This implementation is delayed until October 1st, 2024 for smaller carriers that are below a specified threshold for a number of employees and premiums. The effective date means that the programs must be in place and in writing. The MIA may require you to produce a copy of the program as part of an update following your report of a cybersecurity event. It may also be required as part of a market conduct exam. On or before April 15th of 2024, a certification of compliance with 33103 must be filed with the MIA. There is an exemption for carriers that are not domiciled in Maryland, but are domiciled in another jurisdiction that has adopted a substantially similar law, is subject to that law, and is required to file, and does file, a certification of compliance with its domestic regulator. And at this point, I can say that adoption of the NAIC model would be a substantially similar law. And if there are assertions regarding another state, we are happy to get that information and consider that. The MIA will be sending a bulletin with information on filing the certificates of compliance. And I encourage everyone to review the statute and let us know if you have specific questions about the implementation of that law. Thank you.
Thank you, Mary. And as Mary said, a bit more to come on the implementation, the full implementation of the information data security law that was enacted last year. I will say that the MIA has had a successful procurement with respect to our network adequacy MAPIA work. So we've made our selection. We expect that to move forward expeditiously. So within the next, let's just say 2 months or so, we should have that vendor on board to provide additional support to our review activities. In addition to that, you will see an RFP coming out within the next several weeks that is focused, among other things, on cybersecurity program analysis, so that as we move forward with the oversight of compliance with the Information Data Security Act, we will have the necessary tools and expertise to assure that plans are in fact compliant with state law and when we get to the point where we are verifying that compliance. So just wanted to let you know that was also in the offing. Does anybody have any questions for Mary that they'd like to address now as opposed to the end? I'm going to see if anybody has their hands raised. All right, I don't see any. So thank you, Mary, for another clear, precise presentation. And we're going to move on now to Joy Hatchett and Mary Quay to talk a little bit about our hurricane season and the MIA response in the event of a disaster. But Joy, before we jump into that part of the agenda, I want to hijack you again for just a second and talk about, just very, very briefly, the fact that, and some people have probably already heard some buzz about this, but one of the things that the MIA is going to be doing through Joy's unit, the Consumer Education and Advocacy Unit, is breaking out the assistance that we provide in terms of education and advocacy within our remit to Marylanders with regard specifically to health insurance. And that includes behavioral health, as well as generally helping people to problem solve through figuring out coverage and how to get to their carriers, how to talk to their carriers. So facilitating people's awareness of how they use the insurance that they just bought and how they work through some of the challenges about coverage and even where to go within, with their own carriers to get that information long before we get to a point where the MIA has an enforcement role. We are standing up 2 directors, one focusing on behavioral health, one focusing on, health insurance usage generally, health coverage generally. And with that, Joy, if you would share with us, I know I'm putting you on the spot a little bit, but just briefly, what you see happening, and then obviously much, much more to come. And one of our new directors, who is not new to the MIA, but I would say new to the title, because I think Patty's actually been doing this work for a long time. So Joy, if you want to give us a little update, that would be amazing.
Thank you, Commissioner. And so, as most of you know, one of the major things that the Commissioner has had us continue our focus on is reaching out and helping consumers along the way. And for years, we've done a lot of that on the property and casualty side, but there's a real need, as we all know, on the health side. And we've seen that need, whether it relates to physical issues and concerns, but especially on the behavioral health portion of that. And we've seen numerous opportunities and legislation has been tried to go through the process. And we're still in that process. And one of the things that the Commissioner wanted to do was, let's start now. Let's not wait until actual legislation passes based on the severe need for our consumers in Maryland. And so the initiative that we're working on, and it is being developed, is basically trying to assist people much more, as the commissioner mentioned, understanding their policies, co-pays, deductibles, co-insurance. Those are very difficult terms. And consumers sometimes, because if they don't understand those terms, hesitate to use their insurance product. And so one of our efforts, and a major effort that's going to be led by Patty, and if any of you have ever worked with Patty, you know how passionate she is about this, helping people understand. So that is really going to be her focus, trying to help folks understand what they've purchased and make informed decisions and understand what the next steps are. And then the other big thing that we're going to really start doing, and we're in the process of hiring the director for, is the behavioral health piece of this. And that piece, we all know about the gap there. People don't understand how to get the services, where to get the services, what any barriers are. So we're really going to spend some time and basically trying to help them walk through the process. We're not just going to say, okay, here's a brochure, go read it and figure it out. We are going to really walk with them side by side. And so we're going to be reaching out to many of you to find out what you as carriers, people who are in the insurance arena, your ideas, so that we can try to meet people where they are and try to help fill in those gaps.
Thanks, Joy. Patty, did you want to add anything?
Just that this is exciting. I think Joy did an excellent job describing the initiative, describing what we're getting started doing. And I am definitely looking forward to hearing from those of you who are attending. If you have ideas and feedback for me, it's much appreciated.
Yeah, I think it's going to be a terrific initiative. Our goal is to problem solve earlier, not later. A lot of that sometimes is really, as we discovered in the P&C world, it really is connecting the consumer with the right person at the carrier. We can help with that. We'll be coordinating with other state agencies, including the Maryland Department of Health, as they map out, where people can go for what kinds of services. So this will be very much a collaborative effort. We'll be working with MHBE, for example, as we talk about, how and coming alongside the Navigator program where it's appropriate to help people understand what they just bought. So we are very much looking forward to launching this. We have our consultant, Diane Stolenwork, who's done a lot of work with the Maryland Department of Health in place. We are in the middle of our two additional hires, as well as contract employees, and we are working with some grassroots organizations so that part of what we're doing is really moving into communities in a particular way. Some of that effort and some of these efforts will also be focused on a more deliberative approach to outreach to undocumented people who reside in Maryland. So the CEAU unit has already done that work as part of their community outreach when they are in communities. So whether they're at churches or at neighborhood festivals or any place that they get farmers markets all over the state. I mean, Joy's team does literally hundreds of outreach events and as many as a dozen or more during the week in the summertime. But now we're going to bring in an additional deliberative overlay to that. and work with community organizers to help better target and understand how we can reach people within that the undocumented community, to make them aware of what they can acquire in terms of ACA coverage, and eventually, and as a secondary approach, what other kinds of services or coverages they may be able to frankly better afford. And then we'll be collecting and sharing that data as we go. So I wanted to highlight that because I'm really proud of what Joy and her team are doing. And I think it's going to have a really positive impact on our state. And I think it will also provide valuable information both to the Behavioral Health Commission and to the legislators. All of them are aware that we are doing these things as they look forward to considering different programs going forward. So with that one, I will now stop hijacking Joy and let Joy and Mary continue on to talk about preparation for hurricane season, how the MIA will respond in the event of disaster, including our virtual disaster centers, which is the most fun thing that I think we've done since I've been here. So off you go, Joy.
Thank you, Commissioner. So as most of you know, anytime that there is a disaster that's been declared a disaster, we have emergency powers that allows us to either ask or require that certain steps be taken. So on the life and health side, those steps could include removing restrictions on refills for prescriptions or doable medical equipment, of things of that nature. And this, we just want to remind you that that could happen. Let's hope it doesn't, but generally at least once a year, there is an emergency that has been declared, and the need to basically exercise our emergency powers is in force. Now, at the beginning of every year, everyone should be updating their disaster contacts, because that way we know who to reach in the event of a disaster. Because what ends up happening is, if we have a declared event, and if you're going to be required to relax your prescription refills or your DME requirements, that's the way you're going to learn, because a blast email will go out to the person that's on the list. Well, if the person that's on the list has retired and you have not notified us, then you basically will not receive that alert. So it is incumbent upon you to make sure that throughout the year, if your contact person changes, you need to let us know. And if you have any issues with that, then you should reach out to Joyce Peach, and she can make sure that your contacts are in fact up to date. But once again, let's hope that we don't have to use this year, but just in case, make sure that your contacts are up to date. And now I'm going to turn it over to Mary so she can talk about if in fact we need to gather any information from you about claims or things of that nature.
Thanks, Joy. As Joy said, market regulation includes multiple units, and you probably associate us with market conduct, which we would hope that if the market conduct needs to help Joy with any enforcement, that we can do so nimbly and quickly, even though full exams are neither of those things. However, what Joy is referring to is that we also have a market analysis unit, and their purpose is to collect data you might be familiar with their surveys in other contexts. Sometimes we get a question from a legislator or a question arises within the MIA. And instead of doing a market conduct exam or other market conduct action, what we do is have market analysis send out surveys. And they can do this on an industry-wide basis. As with other actions that emanate from market regulation, we do have due dates. We will enforce those due dates as appropriate, keeping in mind that, yes, you may also be struggling with the after effects of a disaster. But it is important for us in conducting these data collection efforts that we have clear communication. And so these requests may go out to your market conduct contacts, but make sure that we do have up-to-date contacts for that as well. And I think that's all I need to say on that subject, but thank you.
Okay, thank you, Joy, and thank you, Mary, for those updates. So that concludes our formal agenda. So let me just ask folks, I know Kate Kiernan, I think you had, I missed your hand raised before. I don't know if you still have a question or a comment. Let me look and see who's got their hands up. There we go. I see Kate. So let me go ahead and bring you over.
Hi.
You're
Hi,
now
Commissioner. Can you
here.
hear me?
I can hear you. I can't see you.
Yeah. Oh. Well, let's see. There we go.
I promoted you to a panelist, so hopefully, and now you're on mute.
Sorry.
There you go. Perfect.
Oh, sorry. And I actually was slow on raising my hand. I had a question for the cybersecurity information that both you and Mary provided. Do you have the vendor name for the certification that we're going to need to do for the cybersecurity, or should we wait until the fall?
The certification forms will be due next year. And we are in the process of setting up email boxes here where they can be filed and methods for you to file them. And that's what the bulletin will address. Now, we may have questions or require submission of the processes, your written processes prior to then for compliance reasons arising from an event or otherwise. However, the filing of the certification of compliance is due early next year, and we will send out a bulletin with the details of how to submit it.
And we're not
Great, thank you.
intending, Kate, that, and Mary will correct me if I'm wrong, but we're not intending that you submit your certification through a vendor. You would submit your certification directly unless you're immune or not, that you don't have to do it because you meet one of the exceptions. And then, of course, everything that Mary has said is subject to the caveat that's in the statute as it relates to small insurers. So, you know, that don't have to comply yet in 2023, but where it would become applicable in 2024. The
Great, thank you.
vendor is the vendor we're going to use eventually to do market conduct reviews for compliance.
Great. Thank you so much for the clarification. And thank you so much for all of the presentations. This has been educational, very much content rich. Thank you.
Thank you. Hey, Matt, how you doing?
Hi, Commissioner. How are you?
Good, thank you. Welcome back.
Thank you. Thank you for letting us have the opportunity to ask some questions. And I sent along my question to David, I don't know, Monday, which I know is a holiday. So we might not have the answer yet. But my question is around the weight loss drug Ozempic, now that there's off-label use. I had a couple of carriers, league members ask me about this drug, and I know there's a mandate for surgical procedures on morbid obesity treatment, but there's not language on prescription drugs. And then I'm told that by some of the members that the MIA has required coverage in the small group market through form review. And I'm just looking for some clarification on the drug because I'm not exactly sure how we're supposed to approach it. That's it. Thank you.
All right, thanks, Matt. Yeah, we can answer that today, and thank you for the question. Yeah, I can confirm that under current Maryland law and regulations, there is no requirement to cover any weight loss drugs, which would include Ozempic. As you mentioned, the mandate under 15839, that's just for the surgical treatment of morbid obesity, does not include weight loss drugs. There is the ACA preventive care benefit does require certain weight loss interventions, but not weight loss drugs at this time. Even with the new fact that there's off-label use for these drugs, and Maryland does have a law requiring off-label use of drugs, that law would not override any kind of contractual exclusion for a specific treatment or drug. So basically, if the contract does not cover any weight loss drugs, you wouldn't have to cover off-label use of the weight loss drug either. So I'm not sure where you may be hearing that anyone at the MIA said it was required from small group plans. I did talk to my staff and look into that. We weren't able to identify any place where that comment had been made. We did find one objection to a broadly worded exclusion on preventive services for obesity last year that was made, and it did mention drugs, but the objection to the exclusion wasn't related to the drug component of the exclusion. It was just related to the broadly worded exclusion itself. So I don't know if perhaps that's where the confusion came from, but if any of your members do feel that they've been instructed that they have to cover this currently, you can feel free to reach out to me directly and I can look into it. But again, in the current law and regulations in Maryland, it is not required to be covered at this time.
Thank you as always, sir. Appreciate it.
Absolutely.
Any other questions or comments? I don't see any hands up. Give everybody just another second or two. I'm really bad at this. Okay. Well, I don't see anything. And so with that, I'm going to close our annual Life and Health meeting. I want to thank everybody from my team for their excellent work as also, and thanks to all the participants. If there are questions or comments that follow, something that you think about after the fact, don't hesitate to reach out to us. And by us, I mean the subject matter experts that have addressed those topics on this call. So thank you very much. I will wish you a great rest of the day and see you soon. We'll give you 32 minutes of your life back. Take care. Bye-bye.